A very good afternoon to all our viewers. On a mission to empower you with the knowledge and tools and unite our voices to take action this World Cancer Day, I, Darshika Shah from the Clinical Engagement Team, welcomes you to the Global Onco Conversations 2023. India between 2010 to 2019 saw an increase in the rate of cancer cases from 1.1 to 2%. While the pandemic led to a massive decline in screening, a study reported 1.4 million cancer cases in India alone in 2020. This year, to commemorate the World Cancer Day, DocPlexus brings to you a 3-day event, the Global Onco Conversations 2023, to address several pressing issues around the cancer care gap, where experts from across the country and overseas will participate in various clinical sessions and updates in cancer care to help the community of healthcare practitioners. DocPlexus Global Onco Conversations 2023 with national and international experts will deliver insights on cancers of the head and neck, treatment of advanced HCCs, multiple myeloma, and accredited CME, and much more on the latest in oncology. So let's begin our 3-day clinical discourse. For today, we have 2 lectures planned. The first one right now would be an international speaker program for Global Onco Conversations with 2 eminent speakers discussing on the treatment of advanced HCCs and multiple myeloma. Next, at 5 p.m., stay tuned for a DocPlexus surgery suite on liver surgery for malignant disease, current perspectives by Dr. Saumil Vyas. So moving ahead, welcome to this lecture with our international speakers. First, we would be discussing on hepatocellular carcinoma, which is the 4th most common cause of cancer-related deaths across the world with about 72% mortality rate in Asia. The first line of treatment of HCC was limited to multi-kinase targeted inhibitors, but now have expanded to immunotherapy agents. To know more about the management of advanced HCCs, we have an expert here with us. Please welcome Dr. Cho Supin. She's a medical oncologist at QD Oncology in Singapore. Dr. Supin is a medical oncologist with expertise in treating gastrointestinal cancers like colorectal, upper gastrointestinal, pancreas, hepatobiliary, peritoneal, and anal cancers. She has headed many clinical trials in gastrointestinal cancers and was also the deputy head of the Clinical Trials and Epidemiology Sciences Department in NCCS. Her research areas of interest include pancreatic hepatobiliary cancers and immuno-oncology. She also founded the SSO Cancer Immunotherapy Consortium and is the honorary secretary of the chapter of medical oncology at the Academy of Medicine in Singapore. She was the first female president of the Singapore Society of Oncology as well in 2018. It is a pleasure to host you here, ma'am. Over to you.
Hi, good afternoon, everybody. My name is Supin Chu. I'm a medical oncologist specializing in gastrointestinal cancers from QE Oncology in Singapore. And I'd like to thank the organizers, DocPlexus, for inviting me here today to be part of this global onco conversation about the treatment of advanced hepatocellular carcinoma. These are my disclosures. So in the treatment of advanced liver cancer, we have made a lot of progress over the years. If some of you in this crowd who are not so young may remember when sorafenib first came onto the treatment landscape, was the first ever targeted therapy that showed survival benefit compared to placebo in advanced liver cancer. And that was the only drug we had for many years after. But in now 2022, now actually 2023, we have multiple drug treatment options for advanced liver cancer, including immunotherapy, as well as other TKIs and anti-VEGF therapies. So I will just firstly talk about first-line treatment of advanced HCC with a focus firstly on monotherapy and what the monotherapy phase 3 randomized clinical trials have shown us. The first drug, as mentioned, was sorafenib in the first-line setting of advanced HCC, which I'm sure many of you are familiar with. The data came out from the SHARP and the Asia Pacific trial, 2 trials that were almost identical, one conducted in the West with largely Hep C related HCCs, and the other one conducted in Asia Pac with largely hepatitis B related HCCs. And the magnitude of benefit with sorafenib compared to placebo was exactly the same, almost identical, hazard ratio of 0.69 and in sharp 0.68 in facial PET, showing the benefit of sorafenib, with the median OS at that time of about 10.7 months in sharp. Many years later, in about 2018, after many failed clinical trials, lenvatinib, another multi-kinase inhibitor, was shown to be not inferior to sorafenib in terms of OS, with the median OS of 13.6 months. Okay, it also showed better PFS of 7.4 months compared to just 3.7 in sorafenib, and a very impressive overall response of about 20%, based on mRECIST. Moving along more recently, in the last 5 years or so, we have single agent immune checkpoint inhibitors in the first line setting for HCC. I won't go into the details of the trials. There's just too much data to discuss today. The first trial was Checkmate 459, looking at nivolumab and comparing it with sorafenib in the first line setting. And it was a negative study because nivolumab was not shown to be superior to sorafenib in terms of OS, which was the primary endpoint. However, the median OS with just nivolumab alone was an impressive 16.4 months. That you can see the curves on your right. You can see that nivolumab, eventually you have what we call the IO tail of the curve, but there are some patients that continue to benefit from the monotherapy IO agent. The response rates with nivolumab was about 15%. And similarly, more recently, in the Himalaya study, there was an arm that used durvalumab as a single agent, and it was compared to sorafenib. This was for non-inferiority, and this was a positive study in that durvalumab was shown to be non-inferior to sorafenib. And again, you have very similar median OS of about 16.6 months with durvalumab. Okay. So, and in both these more recent liver cancer trials, the control arm with sorafenib had very similar OS of about 13 months. ESMO last year, tislelizumab, which is another anti-PD-1 agent, was also shown to be not inferior to sorafenib in the Rationale 301 study. These included patients who had not had systemic therapy, all Charles Blue class A, either stage B, C, or B, were not amenable to local regional therapy. And you can see again very similar OS of about 15.9 months with tislelizumab. There was also a higher response rate with tislelizumab, as shown in the table on your left. We had responses of about 14%. As expected, these IOs, longer duration of response in this study is quite significant. The median duration of response with tislelizumab was 36 months compared to just 11 months with sorafenib. So AEs in the study, there were more grade 3 toxicities with sorafenib, and about 12% of patients on the tislelizumab required steroids for immune-related adverse events. So I'll put a chart. We should be comparing trials, doing cross-trial comparisons, but we just have a numerical view of what the effectiveness of these drugs are. I've just put all the first-line therapies in this chart here. And overall, we have seen improvement in OS with the monotherapy immune checkpoint blockers, though lenvatinib does numerically have a better OS, PFS, as well as ORR compared to sorafenib. So with the anti-PD-1s, there's consistent data across in terms of median OS of about 15 months, response rates about 15%, and we are seeing the OS with these trials at about almost 40%. On to combination therapy options in the treatment of advanced HCC. We have the IO combinations, IO plus TKI, as well as IO anti-VEGF mAbs. And there have been many trials reported over the last couple of years and a plethora of data. The important study, I guess, is the INBRAVE 150 study, which showed the superiority of atezolizumab plus bevacizumab compared to sorafenib in the first-line setting for advanced HCC. These patients were randomized 2:1 to receive atezo-bev, and the other control group was just sorafenib as is usually given. Study met its primary endpoint of overall survival benefit with the median OS when later updated as 19.2 months with atezo-bev compared to just 13.4 months with sorafenib with a hazard ratio of 0.66. So survival at 18 months in the updated data analysis was 56% with the atezo-bev. So in responses also were almost double what you get with single agent ICB. ORR with atezo-bev was 30%. As you remember, with monotherapy, it's about 15%, and this is currently the gold standard for first-line treatment of advanced HCC. One thing to note in this clinical trial was that all patients had a mandatory upper endoscopy. For most of us, we would recommend using this, doing an OGD before subjecting a patient to such high-dose bevacizumab for the risk of esophageal variceal bleed is not insignificant. This is the same trial, but just looking at the China cohort, and you can see the curves sitting very nicely and showing a median OS of 24 months. Certainly, this group of patients do benefit from this combination as well. China does have a similar study. This was presented previously called the ESMO Asia. This was called the Orient 32 study. Was using very similar to atezo-bev, sintilimab, which is an anti-PD-1 made in China, in combination of biosimilar bevacizumab, and the patients were compared to sorafenib in the first-line setting. Okay, and this study was a positive study because it showed both superior overall survival, superior PFS, almost double that of sorafenib, as well as superior overall response of 20% compared to just 4% of sorafenib, without any significant concerns about adverse events too. The first trial to show the IO-IO combination being of benefit is the Himalaya study. This was actually multi-arm study of 1,324 patients. Of note, this study did not include patients with main portal vein thrombosis. Okay, and OGD was not required for this study. So this study initially had two combination arms, which had tremelimumab at 75 milligrams every 4 weeks plus durva, okay, at 4 weekly. And then what we call the STRIDE regimen, which is tremelimumab, one single dose at 300 milligrams, and then the durvalumab, 1,500 milligrams every 4 weekly. The arm with the T75 was closed because of toxicity issues, and the trial continued with just the STRIDE arm compared to durva compared to sorafenib. The main objective of this study was to show that STRIDE was superior to sorafenib, and this objective was met with the OS benefit seen in the chart here. Okay, with a median OS of 16.4 months with STRIDE compared to 13 months with sorafenib. S was not significantly different, though there was a trend towards it. And overall response was also better in STRIDE, 20% ORR compared to just 5% with sorafenib. Study that took a slightly different approach was a combination of IO with a TKI. And this was the Cosmic 312 study, which was presented at also at ESMO Asia a while back. This study looked at cabozantinib plus atezolizumab, and that arm had sorafenib, and another arm had cabozantinib. The aim of the study was to compare the combination of cabozantinib and atezolizumab with sorafenib, and also compare cabozantinib with sorafenib. As I said, there were two primary endpoints in the main study, and the main gist of this study is that cabozantinib and atezo did increase PFS and overall response rate over sorafenib. However, there was no difference in OS. The toxicities with the cabozantinib is an issue. And while this is a positive study in terms of the PFS being met, the OS was not statistically significant. Other study also presented at ESMO last year is also pembrolizumab and rivoceranib. And this was a study conducted in first-line setting as well, then compared to sorafenib, but in a one-to-one randomization. And pembrolizumab plus rivoceranib improved OS, PFS, and ORR compared to sorafenib. Of note, majority of this study had Asian patients. About 80% of them were Asian patients. Again, this combination of a NIP with the IO had a response rate about similar to the other studies, about 20%, and the median OS was about 22 months. LEAP 002 was a highly anticipated study looking at the use of lenvatinib with pembrolizumab. Again, this study of note did not include patients with main portal vein invasion. Okay. And required OGV within 3 months of randomization. But in this study, unlike the rest previously mentioned, the control arm was lenvatinib and not sorafenib. The primary endpoint was a dual primary endpoint OS as well as PFS by RECIST. So this study did not was negative because it did not meet its primary endpoint of survival benefit. As you can see in the graph here, okay, the median OS with pembro lenvatinib was 21 months, and with lenvatinib alone, it was a very impressive 19 months, and the P was not statistically significant. Okay. There was also no difference in the PFS, median PFS, but at 24 months, as shown here, the PFS was higher, 16.7% of patients in the combination had not progressed compared to just 9% with monotherapy. There was a higher response rate with the combination with a ORR of 26% compared to just 17% in the lenvatinib alone. But that 17% response for lenvatinib is also very impressive. The lenvatinib arm did really well in this study, which probably explains why it turned out to be a negative study, though we all expected this combination. We know this combination can be active. Okay. In terms of safety, nothing more than what we already expect, since you're familiar with both agents, lenvatinib and pembrolizumab. About 9.6% of patients required steroids in the pembro arm. To put all the phase 3 trials using first combination therapies in first line advanced HCC, list them all here. These are the positive trials. And you can see that there's some differences between all the studies. The sintilimab trial is really just Chinese patients only, as it was a China-only study. Well, most of the other studies included a mix, a group of patients from both East and West. And that's reflected in the etiology of the cancers as well. Okay. Short of the median OS and the efficacy of these combination therapies, generally speaking, you're talking about a response rate when you use combination of up to 30%, especially the Tisobev, of about 20 months. And we can say this, we've made lots of improvements since the days of sorafenib. One needs to know the toxicities between the combination therapies in order to make the right choice when faced the patient, and certain toxicities may or may not be acceptable to certain patients. For example, with your IO Himalaya stride regimen, we expect more immune-related. And in this study, the use of steroids went up to 20%. Okay, but with bevacizumab, cabozantinib, then one has to contend with hemorrhage being the more common problem compared to the other combinations. The camrelizumab rivoceranib study, at least in the presentation so far, suggests fairly high cutaneous endothelial proliferation, up to about 30% of the camrelizumab, and about 3% of patients and 33% of patients, which is very high, had hepatotoxicity that was grade 3 or 4. Okay. We are all still waiting for one more big trial with studying the combination of IO, nivolumab, and ipilimumab. It's a CheckMate NDW study, which is has been compared with sorafenib or lenvatinib, which is up to the physician's choice. Completed recruitment and just waiting for the results to be announced. So how about the second line setting? We've sort of talked about many choices in the first line setting. The problem is that most of our studies in the second line setting were conducted after failure of sorafenib. We don't have data for studies after IO or after IO combination. So these are the target therapies in the second line setting. And all these are in patients who have progressed on sorafenib. Cabozantinib's Celestial trial was the only one that included some patients also in the third line setting who had sorafenib plus something else before they were enrolled in this patients at third line setting. But generally speaking, you can see across the board the median overall survival with these single agent targeted therapies is about 10 months. And the response rates are not more than 5 to 10%. Very modest duration of response of not more than 4 months with any of these agents. So there are some differences with the utility based on the trial design. Remember, regorafenib should be used if you follow the trial after patients had tolerated and progressed on sorafenib. The ramucirumab is only used for in patients who have AFP more than 1200. For immune checkpoint blockers in the second line, there are also numerous studies, both the only one phase 3 one, the rest are phase 1 or 2 studies using nivolumab, pembrolizumab, as well as a combination of nivolumab and ipilimumab. Even in the second line setting, the monotherapy with nivolumab, pembro, have very similar efficacy compared to the same agents in the first line setting. But the EP-nivo combination, as shown here, achieved responses of 30%, and this is in the second line setting, which shows its efficacy. So this just tells you same thing as the previous slide of just overall what monotherapy checkpoint inhibitors do in the second line setting. One thing to note is that PDL expression does not correlate with response in liver cancer. It's not a good biomarker for determining a patient will respond to immune checkpoint blocker or not. But what we know, even with monotherapy ICIs, is that patients can get good responses. And when they get good responses, they are very clinically meaningful. For example, we can show that here patients who achieve complete or partial response have very prolonged median OS, and this can last for years. Okay. So I mentioned about the keynote 240 trial, which was pembrolizumab compared to placebo after one failure of sorafenib. Though this was a negative study, as it didn't meet its co-primary endpoints of both OS and PFS. The activity of pembrolizumab in this study is very similar to what is seen in all the other monotherapy IO studies. The keynote 394 phase 3 trial also, but this one was mainly in Asian patients. It's only in Asian patients. 65% were from China, the rest were from Korea and Malaysia. And this had a single primary endpoint of overall survival. This was a positive study, probably because of the skill difference in design compared to the previous keynote study. And again, very similar objective responses and median OS compared to any other monotherapy trial. So I just want to mention the Nivo-IPI study, which because US FDA has approved the combination of IPI-Nivo as in the second line setting. And it's based on the Checkmate 040 study, which had a cohort that included this combination. And the study, there were many various versions of IPI-Nivo, but the one that showed the best efficacy was the Nivo-1 IPI-3. Shows the IPI-Nivo-1 IPI-3 arm having superior OS compared to the rest, with a 42% of patients being alive at 36 months. Okay. Higher response rates are also seen with the IPI-Nivo of 10%. Okay. However, there are some more safety issues with IPI-3-Nivo-1. There's 20% of patients who had discontinuation of therapy due to drug-related events compared to, if you want to compare to just monotherapy, obviously there's cross-trial comparison, like with pembro alone, the discontinuation rate is only about 4%. Okay, and about hepatitis in this group was as high as 20%, and or more half of patients require steroids. So while this may be a combination that is effective, the concerns about IRAs need to be highlighted. However, when patients need a higher response rate, this may be a small group of patients that may benefit from this combination. Just the same stuff that I've said, summarized in the table. Okay. So what are the factors to consider when we decide on first line and second line therapy advanced HCC? I think we are very clear where the data is. However, because there are choices, it makes it harder to decide on what to give the patient, and treatment choice has to be individualized to the patient's situation. But for example, you have to consider patient factors. Obviously, patients who have previous transplantation will not use an ICB agent. Patients at high risk of bleeding would not prefer atezolizumab because of the risk of bleeding with bevacizumab. Similarly, for patients with uncontrolled autoimmune disease or any other situation that prevents them from receiving an immune checkpoint blocker, then we may have no choice but to use a TKI in these patients. Now, of course, ages are important. If a patient has a very high tumor burden with impending visceral crisis, or very aggressive cancer, you might be leading a combination therapy with a higher response rate versus something that is has a low response rate but has a really good median OS. Okay. At the moment, I think etiology, apart from the sorafenib that is shown to appear to have better outcomes in HCV-related HCC, there's no clear biomarker statement that we can say that patients who are Hep B versus Hep C should receive one or the other treatment, because these therapies have been shown to be active in all etiologies. Of course, safety profiles have been considered about patients having related AEs, and patients' lifestyle, whether they are would be very upset with hand-foot syndrome versus a patient would prefer ICU. Okay. And then, of course, there are issues of reimbursement and cost of drugs and what's approved in your country as well. One of the key things about advanced HCC and all this very effective systemic therapies is whether or not we should be moving systemic therapy to the intermediate setting. Okay, I'm not going to talk about doing intermediate stage of patients. Just threw this out to show that our threshold for doing repeated taste in the intermediate stage is not as before. We tend to be doing less taste because now we have very effective systemic therapies, right? Whatever it is, the treatment landscape for advanced HCC has become ever more complex, as can be seen. Small guidelines here. In the past, we had just one drug here, and now we have multiple options. And this list is growing because there are still other drugs that are going through FDA approval. I think Durva and Tremi are already approved. Then how about the other drugs in other jurisdictions? Sintilimab is used in China, though not approved in the US FDA. And beyond all this, undergoing in the trials at the moment are other IO drugs that are being combined with PD-1 or CTLA-4 inhibitors. And there are many other studies ongoing, including vaccine studies and so on. Okay. Of interest, if you're talking, is this adjuvant study? This was just announced a few days ago. Adjuvant atezo-bev combination meets RFS endpoint early stage HCC. This is the EMBRAVE 050 trial. We await the data, of course, because all they say is that the study met its primary endpoint. Okay. So in conclusion, atezolizumab and BEV is the standard for first-line treatment of advanced HCC, and so is tremelimumab based on the Himalaya study. Alternative therapies in the first-line setting include lenvatinib and sorafenib. In second-line and beyond, there is data for both TKIs as well as immune checkpoint blockers. Unanswered questions would include the best sequence of drugs, best combination to use, and we don't have any very good biomarkers to decide on best approach for each patient. Moving forward, there are many real-world studies collecting data to see outcomes after the various combinations and so on, but I don't have time to go into that today. Of course, managing the toxicities, especially those related to immune-related adverse events, needs to be actively addressed, and we need to work with our other subspecialty friends to ensure that patients are properly managed. And there are more combination therapies emerging that will change the landscape further, and we're moving all these combination therapies in time in the earlier setting of liver cancer. Whatever it is, survival outcomes have improved significantly for advanced HCC, and this is good news for all our patients. Okay. So with this, I thank you, and I'm happy to take some questions.
Thank you so much, ma'am, for this wonderful lecture. We have a couple of questions for you. So my first question is, transarterial chemoembolization in patients with advanced HCCs due to portal vein thrombosis has been suggested to improve overall survival, but is currently not recommended by practical guidelines. What is your expert opinion on this?
In the old days when we had no effective systemic therapy, we used to taste every HCC that could walk or could walk. So, okay. And that's because of the many trials that were done in the past that showed taste had efficacy, and taste improved survival compared to no therapy or placebo. And there are at least 2 large randomized trials in the past, one done led by Spanish guys, another led by the guys in Hong Kong, that showed that survival benefit. But there are many other trials in between, and one of the main issues with all those trials were that patients were not exactly the same. A very heterogeneous bunch of patients. Some had main portal vein thrombosis, some had very big tumors, some had multiple but smaller tumors, some had bunch portal vein thrombosis, and so on. But generally speaking, in a patient, based on BCLC staging, based on our current guidelines, if a patient has main portal vein thrombosis or even branch on the side of the tumor portal vein thrombosis, we would not routinely recommend TACE for the concerns about worsening the liver function of the patient. I think now with so many active systemic therapies available, our aim should be to preserve the patient's liver function as far as possible, so that we can offer the patient as many systemic therapy options as possible. And you can see from the data that some patients have very good responses to therapy. TACE still has a role. I'm not saying it doesn't have a role, but I think we have to be better at selecting patients for TACE. Patients that have very large tumors, or patients that would have compromise of liver function, or patients who have had TACE but didn't respond at all, shouldn't be TACE further, and we should really switch very quickly to systemic therapy.
Thank you, ma'am. Moving ahead to my second question. What role imaging plays in prediction and evaluation of response to therapy?
I think imaging is absolutely important. Else, how do we tell whether a patient's responding or not, especially if a patient doesn't have a very elevated alpha-fetoprotein? And also, we know that alpha-fetoprotein can fluctuate and may not be always consistent with the scan results, though it does help us guide us in the direction of therapy and response in between scans. So for scans for liver, for overall, I would usually stick to a CT scan with contrast if I'm looking extrahepatic as well as the liver. If I only need to look at the liver, then I might do a more specific triphasic liver scan or MRI. PET CT scans are good for extrahepatic metastasis, but are notoriously difficult for liver lesions and can give you very mixed results. So I do not use PET scan at all for liver cancer, unless you're looking at lung mets or something. So generally, I would use just a simple CT with contrast to assess response in advanced liver cancer.
Thank you so much, ma'am. One last question before we close. What should a professional team consist of to meet individuals' overall physical, psychological, spiritual, and cultural needs?
I think at the medical level, it's definitely multidisciplinary. As I mentioned on one of the slides, liver cancer is one of those cancers that requires a lot of specialists. You need an oncologist, you might need a radiation oncologist, you might need an interventional radiologist, you might need a liver surgeon, you might need a hepatologist. And sometimes making decisions on treatment requires everybody's input. For the patient, diet is always a big issue, so it's always good to have a dietitian on hand. In the ideal world, of course, it would be nice to have physiotherapists and occupational therapists as well as psychologists to give patient support. But that's in the ideal world, and in most of our practices, due to time constraints, due to other logistics as well as finances, this is not always feasible. And of course, patients themselves can create their own cancer support group to give each other moral support. But sometimes with that, also we have other problems with that, which is the feeding of myths and other half-truths through the internet and what people read on social media.
Thank you so much, Dr. Pitt, for this insightful and well-drafted lecture for our healthcare practitioners. We would now move ahead to our second lecture for today. We shall be discussing about multiple myeloma, which is a clonal malignancy that contributes to about 10% of hematological malignancies. Treatment ranges from alkylators and corticosteroids and autologous stem cell transplantation in the advanced stages of the disease. We have an expert here with us, Dr. Fadi Nasser, Head of Oncology and Hematology Department at Mount Lebanon Hospital in Lebanon. He is a well-known hemato-oncologist with a special interest in cancer-related clinical trials and tumors. He has research interests in palliative care, end-of-life care, and pain management in cancer. Let us now begin the second lecture. Over to you, sir.
So, good evening. Thank you for inviting me for this excellent meeting. And I will be giving my talk of rapidly evolving paradigms in multiple myeloma after the session of HCC. So, I'm Professor Fadi Nasser, Head of the Hematology Oncology at Hôtel de France, Beirut, Lebanon. And I will be discussing little with you the rapidly evolving field of multiple myeloma. So, when we consider the treatment of multiple myeloma, we have to consider many subgroup and many things in multiple myeloma. First, the frailty of the patient, because like you will see, these patients, if they are frail, so these patients will not do autologous bone marrow transplant. If they're on a good performance status, so autologous bone marrow transplant till now is a standard of care for these patients. So for these patients, we'll look at the age performance status, the comorbidities. We will see the disease morbidity. And, with multiple myeloma, we have the renal impairment, we have the bone disease, and we have the refractoriness of the patient, of the status of the patient. And of course, we have to assess the cytogenetic, we have to assess the IS score. We have to look at the history of the patient. What did he take as a treatment, the previous therapy, the response to the treatment, and what were the toxicity on this treatment. And then the patient-specific factors like accessibility to the drug. Do we have this type of drug in our country, yes or no? The patient preference, he wants to go to the hospital, he wants to be treated back home. What are the goals of the treatment and the lifestyle of the patient? All these, what are the goals of all these subgroups? The goals are to achieve a deep, durable response and maximize quality of life of our patient. So this is likely a resume of the treatment of multiple myeloma. And as you are seeing here, we are dividing the patient to autologous bone marrow transplant eligible or autologous bone marrow ineligible for the patient. For the patient who are eligible for bone marrow transplant, we got an induction treatment. Then we will go for bone marrow transplant, then consolidation of this treatment, and we will go for maintenance. And when he relapsed, so we will manage the relapse. And for the patient who are ineligible for transplant, so as you are seeing here, there's no transplant. We will do induction followed by continuous treatment, so maintenance treatment. And then when he relapses, we manage the relapse. And as you are seeing here, we have to have a progression-free survival one, which is very important. We are trying to expand this progression-free survival one. And then, as we will discuss later on, for the performance, for the progression survival two, so we have many types of treatment, and now we have third, fourth, and fifth line of treatment for these patients. And we know that the treatment on multiple myeloma is evolving very rapidly. So let's discuss in the beginning the frontline treatment with the patient, like we said, ineligible for autologous bone marrow transplant in multiple myeloma. So as you are seeing here, this is a very important study in these type of patients. This is the SWOG S0777 study. And they did take newly diagnosed multiple myeloma randomized to triple therapy compared to double therapy. RVD, so Revlimid, Velcade, dexamethasone compared to Revlimid, dexamethasone. And this is a comparison between triple therapy and double therapy. And the primary endpoint was progression-free survival. And secondary endpoint was overall survival, overall response rate, and safety. So as you are seeing here, triple therapy is better than double therapy. Even in progression-free survival, where the median progression-free survival was 43 months compared to 30 months. So triple therapy is better than double therapy. And also there is a difference in the overall survival for RVD 75 months compared to RD 64 months. So triple therapy is better than double therapy in progression-free survival and overall survival. How about the toxicity? And as you are seeing here, the problem with the triple therapy was the neurologic toxicity, where you have a big difference between the two groups, 4% likely of grade 3 and 76% for grade 2, compared to 21% for grade 3 for the double treatment and only 3% in grade 4. So big difference in the neurologic toxicity, and this is very important for our patient. And this toxicity was due to the Velcade. So this is important for the toxicity for these patients. So RVD is a good example of how a combination treatment in first development then modified in many subsequent steps. Why we are seeing this? Because the dosing interval is very important. In the past, we were given the Velcade as day 1, 4, 8, and whatever. So now we are giving this Velcade as a weekly approach. And the administration of the drug is very important, because in the past we were giving the Velcade as IV treatment. And when we did see that these patients are doing a lot of neurologic toxicity, when we did give this treatment as a sub-Q treatment, so it was the peripheral toxicity was better. So changing from sub-Q to IV or to IV to sub-Q was better to lower the rate of the peripheral neuropathy, which was a big problem for these patients with the triple protocol. How about the grade 3-4 event? They do not always cover the full picture, because even a grade 2 peripheral toxicity was a big problem, and there was a big problem for quality of life of these patients. And at the end, adverse event reporting is important, because how you ask the question for the patient. If you ask, are you doing well? So he will respond yes. But if you go with the details and ask him about his or her neurologic toxicity, so he will tell you, yes, I have a neurologic toxicity, and you have to grade it very well. So how you ask the question for the patient is important, because the answer of the patient will be different how you ask the question. So let's continue with the ineligible patient. Other drugs, other triple therapy. This is the Maya study, very important. Also, this is a triplet with the new DARA. So this is a CD38 drug. We have also triple DARA, Revlimid, dexamethasone compared to Revlimid, dexamethasone alone, until progression of the disease. And the primary endpoint was progression-free survival, and secondary endpoint overall survival, progression-free survival 2, and overall response rate. So also another time, triplet was better than doublet. And as you are seeing here, the 60 months progression-free survival was 52 months compared to 28 months. So progression-free survival was better with DARA RD compared to RD alone. And also it was benefit in the overall survival for the triplet treatment at 60 months, 63.3% of overall survival compared to 53.1. So a big difference between the two. Excellent results for the triplet with daratumumab, the Revlimid, dexamethasone. Also another time the triplet was better than the doublet. So how about the toxicity of this combination? It was toxicity, hematologic toxicity with more neuropathy, neutropenia, and more infection in the arm of triplet treatment. Another important issue with these drugs is the MRD negativity, and as you will see in all the meetings now, MRD is very important, and big questions are to be asked with MRD, and most of our new trials are based on MRD to make decision for these patients. So with this Maya study, as you are seeing here, MRD at 28 months for the triple therapy, 24%. At 36 months, it was 29%. And at 47 months, 31%. So an improving of MRD in time. And another important thing is that a big difference between the triple therapy, where the MRD was like at the 28 months, 24, compared only to 7% in the RDR. So a big difference between the two arms and the MRD negativity, and we will see that this is very important for these patients in the progression-free survival and overall survival, and also a better response in the bad prognostic factor for these patients. Another important thing is the sustained MRD negativity, where you are seeing here for the triple treatment at more than 6 months, the sustained MRD negativity was 20% compared only to 5% for RD and 16% at more than 12 months compared only to 3% for the double treatment. So triple treatment, a big difference in progression-free survival, overall survival, and also in the response and the deepening of the response, so the MRD negativity. So do we have another regimen for these ineligible transplant? Of course, we will not discuss all these regimens. We know that we have many other regimens like the KRD. So you have the efficacy and the adverse event, VCD, DVMP, and of course the RVD light. So like you are seeing here, you have the efficacy of this treatment and the adverse event. So another time, even though for the patient who are ineligible for transplant, the triple treatment is the best way to treat these patients compared to the double treatment. How we will treat the patient as a full frontline treatment, newly diagnosed multiple myeloma transplant eligible. So these patients are in good shape, and we can go and treat them with a triple therapy. And also a key study was the IFM 2009 study. This is a French study where they compared the protocol RVD, stem cell collection RVD, and 1 year of Revlimid. It was compared, so it was randomized for RVD, stem cell collection, so without bone marrow transplant, and RVD and R maintenance. So the difference between the two groups is the autologous bone marrow transplant, and they did look for the primary endpoint, which was the progression-free survival, and secondary endpoint, overall response rate, time to progression, overall survival, and safety. So how about the results? Also, autologous bone marrow transplant made the difference, and it was a positive study with the progression-free survival better with the transplant people compared to non-transplant people, with the transplant people 50 months of progression-free survival compared only to 36 months with the median progression-free survival for these patients. So making the transplant a good option as a first approach in the progression-free survival. But if we look at the overall survival, like you are seeing in the right schema, so there is no difference in the overall survival, and the median overall survival was the same between the two groups. So the autologous bone marrow transplant, a better progression-free survival, but no difference in overall survival. Why? Because most of these patients who did not receive the transplant, 80% of them didn't have a transplant as a second approach when they did relapse. So these are the new results or the updated results, which is published in New England Journal in 2017. This is the PFS2 for these patients. So when they relapse, they did have another treatment. And as you are seeing here, there is no difference in the median progression-free survival 2 for these patients, neither for overall survival after 8 years of following up. And another time, almost 80% of these patients did have a salvage transplant, so explaining likely where these results. So the people who are with the autologous bone marrow transplant, they prefer to go as a first approach when the patient is in good shape to do a transplant. And some people will say they don't like this. The people who don't like the transplant will say there is no difference. I will do the transplant as a second approach after the relapse. Because the progression-free survival 2 and overall survival was like equivalent when there were no difference between the two. So another important thing, this is a meta-analysis evaluating the role of MRD in the outcome. And like I did say, Now, MRD is a very important issue in multiple myeloma, and this is the last meta-analysis done by the Spanish people in 2020, published in Blood. So as you are seeing here, the people who are MRD negative have a better progression-free survival compared to the people who have MRD positive. So a big difference between the two. And if you see the deepening of the progression-free survival, so like you are seeing in the schema at the right, 10.4, 10.5, and the 10 minus 6, the deepening, the sensitivity and the deepening of the MRD, every time the MRD is deepest, so 10.6, every time the progression-free survival is better for these patients. So very important to go and get a very deep MRD for these patients. And if you compare with the cytogenetic, MRD is better than the cytogenetic for these patients as prognostic factor or as indicator for response as for progression-free survival. And this is the same thing for the overall survival, where you are seeing also the same thing. Every time the MRD sensitivity is very deep, so 10 minus 6, every time the overall survival for this patient is better. And if you see the cytogenetic, so there is no big difference. MRD is better than the cytogenetic risk too for the progression-free survival and overall survival of these patients in this meta-analysis. Another important issue, so MRD negativity overcome poor survival risk. Meanings what? If you see in these two schema, the first we have the first two line where they are showing the MRD in high-risk patient, like you are seeing, and when MRD is negative for the high-risk patient, if you do transplant or you don't do transplant, so for these patients, every time you have MRD negativity, so you have excellent results. But for these patients who are MRD positive, where the MRD is positive, so they are at standard risk or high risk, so there is a difference. Meaning what? Meaning if you are MRD positive and there is difference between standard risk and high risk, and if you are MRD negative, so the MRD negativity is will show same results. So this is very important for the progression-free survival and for the overall survival. When you MRD negative, so this is the best thing that you have. You have standard or high-risk patient, and if you are MRD positive, so here you have a difference between the high risk and the standard risk, meaning MRD is very important for these patients. So this is another study. We did discuss the IFM done in Europe, and this is the termination study done in US. And as you are seeing, this is the same study, but done in US. And the difference between this study and the French study, here Revlimid was given until progression, where in Europe, the Revlimid was given for 1 year only. So the same thing, RVD, stem cell correction RVD, and with a comparison. So the other arm was RVD, stem cell collection, bone marrow transplant, RVD. And as I said, the Revlimid was given as maintenance till progression. Primary endpoint, progression-free survival. Secondary endpoint, overall response rate, duration of the response, time to progression, and overall survival. So what are the results? The same results. Progression-free survival was better for these patients who did receive autologous bone marrow transplant. And another time, when you look at MRDs who have higher MRD negativity in the arm of the bone marrow transplant, 54% compared to RVD, only 39%. So autologous bone marrow transplant give better, higher response in MRD. But another time, all the patients who are MRD negative have the same progression-free survival. So giving transplant or not doing transplant, so meaning the people who are MRD negative have a good response for the treatment. They did transplant, yes or no. But when the patient are MRD positive, autologous bone marrow transplant was better than the people who did receive RVD alone. So important this to segregate or to differentiate likely the treatment in the future, and you will see the new likely protocols or the new approach in the research are based more and more on MRD. How about median overall survival? You are seeing in the two group, bone marrow transplant and non-bone marrow transplant. So overall survival was the same with a median follow-up of 76 months. And it was published in the GCO 2022. What is important here, and the big difference between this and the French study, that in this study, only 28% of these patients who did receive RVD, so without bone marrow transplant at the beginning, 28% only did an autologous transplant as a selfish treatment. Why this? Because, you know, in US, we have many new treatments, like you will see, and we have many options other than autologous bone marrow transplant to transplant, and very good drugs and very good treatment as a second, third, and fourth line of treatment, giving this type of results with an overall survival equivalent in the two groups. How about toxicity? So in the arm of bone marrow transplant, the big thing that we know, of course, in the bone marrow transplant, we have more adverse events like neutropenia, febrile neutropenia, and nausea, mucositis, fatigue, fever, pneumonia, which was due to autologous bone marrow transplant. But the important thing is the secondary AML MNDS that occurred in 10 patients receiving the transplant versus 0 patient receiving the RVD. And another important thing is the 5-year cumulative incidence of a maternal secondary primary malignancy, where we have only in the arm RVD without transplant 1.59% of secondary primary malignancy compared to 3.52% in the transplant arm. So this is these were big difference between the two groups of autologous pulmonary transplant, where the transplant can give some problems. How about quality of life? Of course, like you are seeing here, for the quality of life, when the people will do the transplant, the quality of life was not good compared to non-transplant people. But once the transplant is gone, so the period of transplant is gone, so the two curves are equivalent. So these are the transplant in triple treatment. What's coming new? This is coming new. This is the Griffin study, where you are seeing for these type of patients. We have now a quadruple therapy compared to triple therapy. So data, which is an anti-CD38, data RVD compared to RVD. This is a phase 2 study. So this was not a big study compared to autologous bone marrow transplant. Then maintenance RVD for 2 cycles, and then maintenance with 2 years, even with data Revlimid compared to Revlimid alone. And the primary endpoint was segregate complete remission post-consolidation. So stringent complete remission post-consolidation as secondary endpoint, MRD, overall response rate, progression-free survival, and overall survival. So as you are seeing here, the quadruple therapy for the stringent complete remission was higher at the end of the induction, at the end of autologous bone marrow transplant, and after the bone marrow transplant, we have a higher response. And then end of consolidation, first year maintenance and 2-year maintenance. As you are seeing here, we have a higher and very good stringent complete remission compared to RVD. So the quadruple therapy is better than the double therapy. And also when you see the MRD negativity 10⁻⁵, it was favored the quadruple therapy, which is 81% compared to 44% with the triple treatment. So, and when you see the deepness of the MRD negativity, so if you look at MRD negativity 10⁻⁶, you will see the quadruple therapy 36% compared to 15% to RVD. So meaning we have a better MRD responsiveness with the quadruple therapy compared to triple treatment. And if you see the progression-free survival for these two group of patients, the median progression-free survival not reached in either arm, but you see trend towards improved progression-free survival for the the quadruple therapy versus the triple therapy, and the separation of the progression-free survival curve begin beyond 1 year of maintenance, meaning the maintenance also is very important for these patients with a triple therapy compared to one treatment. So this is the Manhattan study, and more new drug, new quadruple therapy. Here we are seeing DARA, Kyprolis, Revlimid, and dexamethasone. So this is a non-randomized study. This is a phase 2 non-randomized trial, and in this study, the primary endpoint was MRD after 8 cycle, and you are seeing more and more the primary endpoint, the MRD, which is very important, like we did say, and the key secondary endpoint, overall response rate, VGPR, and complete remission. So stem cell collection after 4 to 6 cycles for eligible patients. So these patients can have transplant, yes or no, it depends from the doctor. And after 8 cycles, patient received the investigator choice standard of care, early or delayed transplant and maintenance. So for these patients, when they did have the treatment, we have 71% of these patients who did have an MRD negativity. So very high MRD negativity for the DARA KRD, and there was no difference in the grade more than 3 adverse event between DARA KRD and non-safety profile for KRD. So from this study, we have the master study evaluating the same protocol, DARA KRD, and the approach of this protocol, the master protocol, is depending from the MRD. As you are seeing here, we have 81 patients, induction DARA KRD 4 cycle, autologous bone marrow transplant, consolidation, then 4 cycle, consolidation 4 cycle, and maintenance with lenalidomide. But which is important here, as you are seeing in orange, so the MRD assessment as a primary endpoint was done after the induction, after the bone marrow transplant, after the first consolidation, second consolidation, and the maintenance. And also, every time you have 2 MRD negativity, so after induction and after autologous bone marrow transplant, you have the 2 MRD negativity, these patients will stop the treatment. So MRD negative, treatment-free observation, and MRD surveillance. So we'll stop the treatment for these patients after 2 consecutive MRD negativity. So what are the results? The primary endpoint for MRD negativity, 10 minus 5 for all patients is 80%. So post autologous bone marrow transplant for all the patients, 64.5% and 38% for MRD-based consolidation. So as you are seeing, depending from all patients, standard risk, high risk, or ultra high risk, so meaning ultra high risk, they have 2 bad molecular bad prognosis. So you are seeing that they have good response to MRD, and also for high risk, we have lesser response. And meaning here, the ultra-high risk patient had a much higher rate of progression even after achieving MRD negativity. So meaning that MRD is important, but we have to take on consideration also the risk, the molecular risk of the patient. So 2 things have to be considered when we treat these patients: the MRD negativity, the deepness of the MRD negativity, but also molecular risk is important for these patients. At the end, for the patients who are eligible for transplant, this is ESA RVD. So in this GMM GHD7 trial, where ESA did have the FDA approval, so compared ESA, so the quadruple therapy, ESA also another CD38 drug. So we have ESA RVD quadruple therapy compared to RVD, and here you are seeing the primary endpoint is MRD negativity post-induction. Then these patients have autologous bone marrow transplant, and then maintenance for 3 years, or either ESA R or R alone. And the secondary endpoint was complete remission and safety. And as you are seeing here, we have with ESA RVD a better MRD negativity, 10.5 post-induction, which was a big difference between the two groups. Also, in these type of patients, so giving the ESA and FDA approval for this drug for these type of patients with equitable therapy. So for these patients ineligible, quadruple therapy is a good option for these patients, eligible for bone marrow transplant. Quadruple therapy can be an option. And this is the Emory algorithm. This is for newly diagnosed patients. This is an example for in some big center how they go and treat these their patients. So a transplant eligible newly diagnosed multiple myeloma, yes, induction treatment in the high risk. The quadruple therapy with DARA KRD is a standard of care, and for the standard risk, DARA Revlimid, Velcade dexamethasone is the treatment of choice, and they will go from there. And also, if they are not eligible for transplant, if they have a standard risk, so also triple therapy with RD DARA is the good treatment. And if they have high risk of quadruple therapy with DARA RVD light in the treatment. So this is an example how these how big centers are doing and treating their patient. So the big questions at the end of this, the first part, should MRD negativity be the goal for every patient? So what we are seeing, the answer is probably yes. So we need more study to answer directly these patients. How negative is the negative enough? Like we did see 10.5, 10.6, 10.4. So every time you are deepening the response, every time progression-free survival and overall survival are better. The addition of monoclonal antibodies seems to deepen the response and prolong progression-free survival, like we did see. Quadruple therapy is an excellent approach. So are quadruple therapy the future for newly diagnosed multiple myeloma patients? Do all patients need the quadruple therapy? Who gets single versus dual maintenance? How will choice of maintenance impact choice of later relapse therapy? And will MRD status impact treatment management in the future? So like we said, MRD is negative, is transplant will be affected by this approach. If these patients are MRD negative, do transplant has a role? Can it be used to de-escalate and escalate treatment, like I said, and what is missing for the implementation today? So these are the big unanswered questions. And many studies are going to answer these questions. But of course, as you did see, MRD is here to stay. And I think in the likely the near future, MRD will have a big role in our decision in the treatment of multiple myeloma as a first-line approach. So let's go very rapidly for the relapse of these patients. So we have multi-drug regimen in the relapse setting. I will not, I will go very rapidly for the time. So as you are seeing here, we have the newly diagnosed multiple myeloma. Most of our likely, all our multiple myeloma will relapse. So, and the relapse, we have first, the second, and third line treatment. And then after the third treatment, like you are seeing here, we have refractory relapse patient where new treatment are discussed, like the ADC, the BCMA, and the B-specific drug that we will discuss, and the CAR T-cell approach. So we'll discuss these treatment very rapidly with you. So these are the NCCN guidelines for management, and like you are saying, for in the relapse. So this is the first to third prior treatment of these patients. So depending from what did they receive in the first slide, triple treatment, double treatment, quadruple treatment. So this will be decided what the second, third, and fourth line of these patients. So like you are seeing here, we are seeing bortezomib refractory or lenalidomide refractory. So depending from what did you use, the one did you use in the first line approach, so we will have the treatment in the second line approach. So this is the other recommendation regimen in the ERA relapse 1 and 2. And you see we have many options of the treatment with these patients. So what I would like to tell you that many triplets are established by RD comparison, but Is this clinically relevant today? Why? Because many patients treated with lenalidomide maintenance until progression and are refractory at relapse, and more data being used upfront as, like we did see, as quadruple therapy, but data refractory trial enrolled is lacking. And the same thing is said for the people who did reserve. They did have Velcade dexamethasone as a control arm, so we have the same thing to say. So I think this is a progression-free survival for the patient who have a backbone of POMA, carfilzomib as a backbone. So you have here the median progression-free survival of these patients. So you have an idea in the first and the third line treatment, what will be the progression-free survival for these patients, comparing likely the triple therapy to the double therapy, to choose your protocol as in the refractory patient. How about the emerging combination strategy with novel agents, or what's coming? What's coming in the ACTT, like blinatumomab and melphalan, which was used and now withdrawn because the phase 3 study was negative. I will say a word about this. And this is another time the progression-free survival and duration of response with the recently approved therapy, as you are seeing here. So selinexor, we have likely a progression-free survival of 3 months and the duration of response of 4 months. Blinatumomab, 11 months of duration of response and progression-free survival of 2.8. Don't forget the big problems with the eye of these patients. And another time it was withdrawn now because the phase 3 was negative. So it was FDA was withdrawn. We have the new B-specific antibodies with very good results, like you are seeing here, progression-free survival 11 months and duration of response 18.4 months with the teclistamab. And the T-CAR cell, many very good results with the T-CAR cells. The ED cell, 8.6 progression-free survival and duration of response 10.9. And this is the CETA cell where we have at 27 months, non-reached yet, neither progression-free survival and duration of response, very good results. So we will see them a little bit with details in this study. So selinexor, a nuclear export inhibitor currently indicated in combination with the VD after the first prior therapy, or with dexamethasone alone after 4 prior therapy and penta-refractory. A good drug used, a very big problem with nausea and vomiting, so GI problems, and we have to know how to deal with this drug. Other new drugs that we did say a word about them, ADC like blinatumomab mifedotin, like recently withdrawn from the market because of the negative phase 3 study. The CAR-T, we have many approved CAR-T. We have the EDA cell and we have the CETA cell. We will say a word about them. Excellent results, I think. These are good approach in the first line treatment for these patients. That, of course, the B-specific antibody, we have many B-specific antibody like you will see. And we have the FDA approval of teclistamab, and we will see some results at the first line treatment for this patient. Look at the T-CAR cell. This is the EDA cell and the CETA cell. Overall response rate in the EDA cell, 73%, complete remission, 33%, MRD negativity, 26%, progression-free survival, 8.8 months, and overall survival, 24 months. Look at the CETA cell, better response, overall response, 98%, complete response 80%, MRD negativity 58%, progression-free survival 22%, and overall survival not reached yet. Look at the new CAR-T CDD BCMA results, so only 25 patients, but look, overall response 100%, the complete remission 70%, MRD negativity 85%, and progression-free survival and overall survival not yet reached. So these approaches with the CAR-T cell are better and better. We are more familiar with this approach of treatment, and I think this is the future that we will have in these type of multiple myeloma who will relapse. Another good approach, like I said, this is the BCMA direct B-specific antibody, where we have very good results, and we have median prior line of these patients 5, triple class refractory 77% of response, penta refractory 27%, and high risk cytogenic 23%. MRD negativity 26%, progression-free survival 11 months, and overall survival 18 months. So also these B-specific directed antibody are very good, and we have very good results with this approach. These are the new B-specific antibody, BCMA CD3. We have many new things which are coming. We did say a word about teclistamab, who have the FDA approval, but we have many other drugs. We have GP RC5D plus the CD3, the talquetamab, and we have FCRH5 plus CD3, the cefotaximab. So many new B-specific anti-drug coming with very good results, and these are some results with, like you are seeing, the overall response rate between 70% and 90% of overall response rate. So very good new treatment which is coming very soon in the world of multiple myeloma. So the key take home messages and point for the second part of the relapse and the fourth line treatment of these patients, triplet is better than doublet for classical combination therapy. The goal is to treat before clinical decline, optimize survival, safety, and quality of life by selecting treatment guided by patient, disease, treatment-related factors. And as you did see, we have many new therapeutic targets that are coming, and we have an exceptional hope and the combination sequencing option we need to further elucidate with the biomarkers, and that's why how to likely sequence our treatment will be the new future of our studies in multiple myeloma. And I think with these new type of CAR T cell B-specific approach and the ADC will likely prolong the survival of our multiple myeloma patient, and I hope in the near future that we can cure these patients. Thank you very much.
Thank you so much, sir. We have a couple of questions for you as well. My first question is, multiple myeloma being a complex disease, how important is patient education for shared decision-making, which assures compliance?
So as you are seeing here, multiple myeloma is a complicated disease, and the treatment, as you see, is very complicated. So the first line treatment is likely not complicated, it's simple. And education of the patient is very important. One, to explain to the patient if he are eligible or ineligible to the bone marrow transplant is one. And second, to explain for the patient what is the difference between quadruple therapy, triple therapy, and double treatment. And what is the important for the patient to have likely a quadruple therapy, and explain for him why likely cytogenetic is important, and like we said in the beginning, the different decisions that we have depending on the age of the patient, the frailty of the patient, the molecular score of the patient, the accessibility of the drug. So educating the patient is very important because we need to take decisions together.
Thank you, sir. Moving on to my second question. How important is it for the patient as well as the doctor to recognize multiple myeloma at an early stage?
You know, every time you go with the early stage, every time the treatment is better. And you know that multiple myeloma have a pre-disease, which is monoclonal gammopathy of unknown significance or smoldering multiple myeloma. So these days, we have many diagnosed of monoclonal gammopathy and smoldering multiple myeloma, and we have to follow up very closely these patients to treat them from the beginning to have a better likely results for our patient.
Thank you so much. One last question. There are some research going on which look promising, like the antigen receptor T cells targeting B cell maturization antigen BCMA. What is your opinion on this?
So, like I presented here, I did present like the three big new approach: ADC, CAR T cell, and BCMA, B-specific antibodies. And like you did see the results, these results are exceptional. And you know, many of these patients that we did say that they will die soon when they didn't have the CAR T cell and or the new B-specific antibodies, they have like another life. And like you see, the progression-free survival can be gone more than 27 months, and the median was not reached. So I think this new approach will change our story and will change our likely natural history of this disease. And like I said, I hope that in near future, how to sequence the treatment in multiple myeloma, we will have the overall survival will be better, the progression-free survival will be better, and I hope that we can cure some patients.
Thank you so much, sir, for this wonderful lecture. Towards the end of our program, I would like to thank Dr. Nasser and Dr. Supin for taking us through some interesting details about cancer care treatment modalities. Dear viewers, we hope to see you again for DocPlexus webinars. Stay tuned for our next session at 5 p.m. with Dr. Soumil Vyas on liver surgery for malignant disease, current perspective. We hope our healthcare practitioners would have gained some useful insights from the lecture. Please write to us if you have any feedback and queries regarding the DocPlexus events. Until we see you again, please take care. And as I always say, happy DocPlexing and take care.